Hi, I'm Jen Woodard. I'm a geriatrics fellow at the Medical College of Wisconsin, and my job today is to put you all through geriatrics fellowship boot camp. The aging population is rapidly growing in the United States and is expected to reach 73 million people by 2030 over the age of 65. However, by 2025, we're expected to have a shortage of geriatricians that will be about 27,000, and we're not on track to filling that. In fact, in 2022, we only had a 43% fill rate of 177 geriatric fellowship spots. So it is of utmost importance that everyone who sees older adults gets at least a basic foundation in geriatrics. Today, I'll be talking to you about the 5M's, which is an IHI age-friendly healthcare systems initiative in appropriately caring for older adults, looking at medications, mobility, mentation, what matters, and then bringing it all together in realizing that older adults have multi-complexity to them. Objectives for this talk is to use the 5M's framework to provide high-value care for older adults, use some of the tools that I'm going to give you with QR codes to help inform your age-friendly assessment, and hopefully by the end of this talk, you will all become champions for age-friendly healthcare. We'll start with Mrs. M. This is a case that I adapted from the VA Age-Friendly Health System's 4M's and used a little bit of AI magic to create the picture of Mrs. M. So this is kind of a typical office assessment. She comes to see you, you get a past medical history, look at medications, do a brief physical exam, and the question is really, what is missing from this that we can use the geriatric 4M's to provide comprehensive age-friendly care for Mrs. M? So the 4 components, again, of age-friendly evaluation are looking at medications, mobility, mentation, what matters, and wrapping it all up in multi-complexity. So we're going to go through each of these pieces with Mrs. M as our example. So medications. We love when people bring in medication bottles, so we really get an accurate picture of what they're taking. Anytime you're able to simplify either reducing frequency of doses or consolidating doses, that is always preferred. And also, I want to encourage all of you to not be afraid to deprescribe. Just because someone's been on a medication for 20 years doesn't mean they have to be on it forever. And I think we should all do a better job of looking at renal function, making sure dosing is appropriate, and considering things like looking at e-prognosis to say, is there the time to benefit that I think would be appropriate for this patient? I also always encourage people to look at the Beers criteria, which was just updated in 2023 to assess our older adults for potentially inappropriate medications and thinking about what could be safer alternatives for them. So for Mrs. M, we took her from a pretty long list of multiple medications with a lot of variable dosing, and we consolidated what we could. And the other thing that I wanted to point out here is that we changed her from a long-acting plus short-acting insulin to just a long-acting, and that is preferred in the geriatric population. Next up, mobility. So not just physical mobility, but also how are people living their day-to-day lives. So one big assessment for falls is the timed up and go. Very easy to do in an office setting, truly does not take that much time. In this, your patient rises from a chair, walks at their normal pace, 10 feet, turns around, and returns to their chair and sits down. If that takes more than 10 seconds, then you should consider a physical therapy referral because that is an indicator of potential increased risk for falls. I also always encourage people to take off shoes and socks and look at people's feet. How their feet look is really an indicator of how well they're taking care of themselves. If they have, thickened nails, if they have calluses, if they have wounds, please refer them to podiatry. It's a really easy intervention that can save a lot of your patient's mobility. The last portion of mobility I wanted to talk about was ADLs and IADLs, so activities of daily living and instrumental activities of daily living. And I've got two mnemonics for you to remember these. So you can use either the mnemonic death shaft, so death for ADLs, dressing, eating, ambulation, toileting, and hygiene, and shaft for IADLs, shopping, housework, accounting, food prep, and transportation. Or you can think about these things from the kindergarten versus college lens. So ADLs are things that you would expect a pretty reasonable kindergartner to be able to do. So the basic things, kind of getting up in the morning and getting ready to get out the door. And IADLs are things that you would expect a college student to be able to do. Go grocery shopping, do basic housework, manage finances, prepare food, and then also transportation, not necessarily driving, but being able to navigate a transportation system. So for Mrs. M, where we would do a kind of basic, unsteady gait, she's using a cane, going a little more into what are her ADLs and IADLs and where can we intervene to help keep her safe. Especially in a patient with falls, we really want to work on prevention. Falls are devastating. Hip fractures are devastating. So if you have someone who is community dwelling, the best thing you can do for them is keep them safe and prevent falls. Next up, mentation. So screening people for cognitive impairment is not recommended. But if there are signs in your evaluation or anyone expresses memory concerns, the mini cog is the best quick and dirty in the office screening for cognitive impairment. So it is a 3-item list as well as a clock draw. So an abnormal mini cog is impaired recall plus an abnormal clock draw. And at that point, you should consider referral to geriatrics, neurology, maybe neuropsychology for a more thorough cognitive evaluation. I also encourage you to assess all of your older adults for anxiety and depression using the GAD-7 or the Geriatric Depression Scale. For Mrs. M, we went from an informal assessment of her mentation to then a more formal screening where she had an abnormal mini-cog, but also an abnormal GDS and seemed a bit anxious. So we deprescribed some harmful medications. We addressed the mood concerns and are working on helping her increase her social interaction. What matters? I love talking about advanced care planning with all of my patients. I think everyone should have an advance directive, and everyone should talk with their healthcare agents and their families about what is important to them. And I would say not just in healthcare, but in life. I often like to ask my patients, when you're not seeing me, what do you like to do? Because that gives me a good picture of who they are as people. Prepare for Your Care is a great website. It's very patient-centric, where people from any state can go on there, understand a little bit more about how to communicate healthcare goals, preferences, and values, and making sure that we're optimizing, basically all of these components for them. For Mrs. M, we looked a little bit more at her case. So she has a frailty risk because of this weight change, but also as having some pain with eating. We ended up getting her nutritional eval as well as dental, and then evaluated for hearing aids. And hearing impairment is linked to cognitive impairment as well as a decrease in social interactions when people have hearing impairment. We completed a POA and we talked to her about what she should really talk to her niece about and kind of giving them a conversation guide. If you're looking for a little bit more with the geriatric assessment or in geriatrics in general, Geriatrics Fast Facts is created by Medical College of Wisconsin, and it contains kind of bite-sized teaching on a lot of geriatrics topics. So if you're looking for a quick refresher I encourage you to check that out. Also, iPhone users, if you are interested, the GeriKit app, which was recently updated, has a lot of these geriatric assessment components at your fingertips. So I would encourage you to download that from the App Store to help aid you when you're doing your geriatric assessment. So Mrs. M, as we look at her a couple months later, she's got better compliance, she feels better, is getting a lot more services and connections, and we are helping her live the best she can for as long as she can, which is ultimately the entire goal of geriatrics. Thank you so much for your time. Please feel free to reach out and contact me if you have any questions, and welcome to geriatrics.